we were looking at the Journal Club from a recently published article from the New England Journal of Medicine. This is the mycophenolate versus azathioprine as maintenance therapy for lupus nephritis, and this was published recently in November of 2011 in the New England Journal of Medicine. This is also the ALMS trial, the maintenance phase. Well, as an introduction, renal involvement remains the strongest predictor of morbidity and mortality amongst patients with lupus. And despite improvements in the management of lupus, the incidence of end-stage renal disease has not declined. Management of lupus nephritis involves induction phase and subsequent maintenance phase to prevent relapse of disease. Then the options for long-term maintenance therapy remains very controversial. Treatment options have included glucocorticoids and immunosuppressive agents, cyclophosphamide, azathioprine, as well as mycophenolate in recent times. These drugs have considerable toxicity and are not effective in all patients. Recently had the Aspreva lupus management study, also known as the ALMS study, and this was done initially to investigate induction with mycophenolate compared to cyclophosphamide, IV cyclophosphamide, and then after that was done, patients who responded were then randomized to the second phase of the study that would look at maintenance of lupus, comparing the use of mycophenolate to azathioprine. The study did examine efficacy and safety of induction therapy, as mentioned, with MMF for class 3, 4, and 5 lupus. And that study showed no significant difference between MMF and IV cyclophosphamide for induction. And as mentioned, this article is following up with a 36-month study to see maintenance differences between MMF mycophenolate versus azathioprine. The study design, it was a prospective randomized double-blind and double-dummy phase 3 study comparing mycophenolate and azathioprine for maintenance of remission in patients with lupus nephritis. And these patients were enrolled from January 2006 to March 2007 from several continents, as shown. And the study was sponsored by formerly Aspreva Pharmaceuticals, now Vifor Pharma. And the patients' age ranged from 12 to 75 years and all showed either class 3, 4, or 5 lupus nephritis. And they had all shown clinical response to either oral mycophenolate or IV cyclophosphamide during the induction study phase in the ALMS trial. And these patients that responded were then randomized to either azathioprine or oral mycophenolate for maintenance. And these patients were then followed for about 36 months and all events recorded. The intervention done was people received oral mycophenolate at the dose of 1 gram twice a day, or they were randomized to receive azathioprine at 2 milligrams per kilogram per day. They strive to maintain this dose. However, for those who couldn't tolerate medications or had some weight limiting situations, they could allowed to take a minimum dose of 1 gram of mycophenolate daily, or 50 milligrams of azathioprine daily. And they were also allowed temporarily to reduce doses below this target, or a complete cessation of drug for no more than 14 days was allowed. They were also allowed to continue on prednisone at the equivalent of maximum dose of 10 milligrams a day. You could keep your ARB and ACE as well as some non-steroidal anti-inflammatory drugs used to maintain folks with their lupus, were also allowed by the judgment of the investigator. Patients were followed at a pre-specified interval. So the primary outcome was the time to treatment failure, measured as the time until the first event and defined as either death or end-stage renal disease or sustained doubling of the serum creatinine level. Also, renal flares, either proteinuria or nephritic flare. Also, the need for rescue therapy while on maintenance was also assessed. This all made up the primary outcomes. Secondary outcomes were an extension of primary outcomes to some extent. The time to the event for each component of the treatment failure was assessed. The time to treatment failure defined more broadly, and this that is the components of the primary endpoint, as well as some major extrarenal flares, and also for withdrawal for any reason, all combined to make this more broadly defined definition of treatment failure. Also, suspected renal flare was analyzed. Time to complete renal remission also was evaluated, and criteria for complete remission was protein clearance of less than 500 milligrams in 24 hours. Also, absence of hematuria or cellular cast, and an improved or stable serum creatinine, plus or minus 25% of baseline. Also, combined renal and extrarenal remission was evaluated using the British Lupus Assessment Group Category A score for a severe lupus flare in one extrarenal system, or the lack of a concurrent Category B score. And this had to do with moderate lupus flares in 3 extrarenal systems, and this was assessed as a secondary endpoint. Lastly, immunologic variables were looked at with the C3, C4, and anti-double-stranded DNA. Now, the randomization is shown in this table. Starting out with 227 patients who underwent randomization. 116 were randomized to the mycophenolate group, whereas 111 were assigned to the Azathioprine group. People had several reasons for withdrawal, which a higher level of withdrawal in the Azathioprine group compared to the mycophenolate group. People were lost to follow-up, people withdrew consent, fairly equally in each group. Eventually, we were down to 73 people completing the study in the mycophenolate group and 54 patients completing the study in the Azathioprine group. The baseline demographic characteristics, for the most part, looked similar in both groups. You had pretty much all races represented, with white, black, and Asians. Fairly proportionate in each group. Hispanic and non-Hispanic whites were also fairly similar, distributed in each group. So it pretty much was a fairly similar randomization, even to the stages of lupus in the disease, fairly distributed in each group. Interesting to note was persistence of proteinuria despite induction of about 1 to 2 gram proteinuria as a baseline in these groups, showing that the line of division between induction and maintenance probably was an arbitrary line, as people improved to complete remission while being maintained maintenance immunosuppressive, completing the basic demographics in the study. The result of the study showed that mycophenolate was significantly superior to azathioprine with respect to the primary endpoint and also in key secondary endpoints. The hazard ratio for treatment failure was 0.44 with a p-value that was very significant. The observed rates of treatment failure were 16.4% in the mycophenolate group, and this was doubled in the azathioprine group at 32.4%. And when you analyze components of the treatment failure, you find that mycophenolate was superior with renal flare, in which 12.9% flared in the mycophenolate group compared to 23% in the azathioprine group. And this also was significant with the odds with p-value of 0.03 and an odds ratio that was 0.5. Rescue therapy, or the need for rescue therapy with maintenance, was much lower in the mycophenolate group at 7.8% compared to 17.1% in the azathioprine group. Also with significant p-value of 0.02. Time to end stage renal disease, although low in both groups, but was significant with nobody in the mycophenolate group within 36 months of follow-up progressing to end stage renal disease, compared to 2.7% in the azathioprine group with a significant p-value. Also, the time to sustain doubling of serum creatinine also was lower in the mycophenolate group of 0.9% compared to 4.5% in the azathioprine group. Secondly, endpoints showed also similar trends with mycophenolate being superior. When you look at the key secondary endpoint of broad definition of treatment failure, 42.2% showed characteristics of this in the mycophenolate group compared to 56.8% in the azathioprine group. Same applies to the time to suspended renal flare being lower in the mycophenolate group, 21.6% compared to 36% in the azathioprine group. Only major extrarenal flare was about the same in both groups, 6.9% in the mycophenolate group and 6.3% in the azathioprine group, and this wasn't significant statistically. The safety and tolerability was better in the mycophenolate group, is 25.2%. Tolerated this medicine better compared to 39.6% in the azathioprine. Complete renal remission was slightly better in the mycophenolate group at 62.1% compared to 59.5% in the azathioprine group. So overall, a trend suggesting that mycophenolate was superior to azathioprine for maintenance in lupus nephritis. This table showed, this Kaplan-Meier curves showed early separation between mycophenolate and azathioprine when you look at probability of being free of treatment failure. Separation occurred about 3 to 6 months, and so it was quite early, and showing that more people were free from treatment failure in the mycophenolate group compared to the azathioprine group. When you look at the probability of being free of renal flare, again you see separation early, showing less flare in the mycophenolate group compared to the azathioprine group. All this pointing to mycophenolate being superior. When you subgroup analyze some subgroups between looking at the form of treatment received, the region of the world, and also their race, you will notice that these hazard ratios were all on the mycophenolate side, suggesting that this was better. And if you look at the incidence rates in bracket on the mycophenolate group compared to incidence rates in the azathioprine group, generally you will see the trend that things were generally higher in the azathioprine group. So this pretty much suggests mycophenolate as a better maintenance therapy compared to azathioprine. When you look at the incidence of adverse events, and you look at all adverse events, not significantly different. However, when you look at some key differences that occurred, if you look at all adverse events leading to withdrawal of the medicine, well, more people withdrew from the azathioprine group because they couldn't tolerate the medicine and some adverse effect. 39.6%, compared to the mycophenolate group at just 25.2% withdrawing. And this was a significant p-value. So tolerability of the medicine is always a key thing when you want to maintain people. Clearly, mycophenolate appears to be a more tolerable medicine. When you also look at things like, well, for death is a little misleading because this one person that died in the azathioprine group actually did not die from the drug or the medication being investigated, but rather from a traffic accident. So we had to report it because it monitored everything. Interestingly, you have a lot of myelosuppression with azathioprine, which goes with the territory of the medication and known side effect that you have. This was significant. More significant leukopenia with azathioprine compared to mycophenolate. And so, as regards to side effects, it does appear that the profile for mycophenolate obviously is a better profile compared to azathioprine. So, study limitations. Well, the study was not powered to draw conclusions about subsets of patients. Patients with more difficult to treat disease may have been excluded, since only those with clinical response after 6 months of induction, either with the MMF induction or cyclophosphamide induction in the ALMS 1 trial, only those who responded were randomized to the maintenance phase. So if you didn't respond or had more severe disease, you were not randomized to the study. And so we couldn't make conclusions about those folks. Few repeat renal biopsies were done during the study, limiting the ability to draw conclusions about possible treatment benefits with respect to active disease or chronic renal damage. So, and then the long-term outcomes seen typically after 5 to 20 years, including cardiovascular complications or even end-stage renal disease, cannot be determined. The length of time that treatment with mycophenolate needs to be continued is unknown. As we know, this study was just a 36 months or 3-year follow-up for maintenance. So finally, in conclusion, the study concluded that mycophenolate is superior to azathioprine in maintaining the renal response to treatment and in preventing relapse in patients with active lupus nephritis who had had a clinical response to induction therapy with either mycophenolate or IV cyclophosphamide. And that, in a nutshell, is the study reported in New England Journal of Medicine. Thank you.